Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, listeners. It's Lindsay Smith-Rogers. When the U.S. Centers for Disease Control and Prevention makes a recommendation to the public, how much evidence supports it? How was the recommendation developed? Today, a conversation on a long-standing issue, whether the CDC can communicate with greater transparency with the American public. It's a topic of special interest to Dr. Joseph Marine, a cardiologist at Johns Hopkins, and Dr. Peter Lurie of the Center for Science and the Public Interest. They joined Dr. Josh Sharfstein to discuss alternatives for the CDC to enhance public trust. Let's listen.
Dr. Joseph Marine, Dr. Peter Lurie, thank you so much for joining me today on Public Health on Call. We're going to talk about the Centers for Disease Control and Prevention and ways that the agency could become more transparent in its communications with the public. I'd like to start by asking each of you to introduce yourself, a little bit about your background, and how you come to this issue of transparency at the CDC. Dr. Marine, I'll start with you.
Well, good morning, and thank you, Josh, for having me on your program. I'm Joe Marine. I'm a cardiologist at Johns Hopkins. I've been on the faculty for 20 years. I've also been very involved with my professional society, and I've long been interested in the issue of bioethics, about medical communication, both at the patient level and in the society level. And I've been very involved with my society's guideline process and how to communicate those recommendations to the public and also to the scientific community. And I've been very troubled by many things that occurred during the pandemic with regard to scientific communication. So that's kind of my interest in this area.
Great. Thank you. Dr. Lurie.
And thanks for having me. And Josh, actually, I think you're to blame for my first involvement with CDC and transparency. You've probably long forgotten this, but back in the 2000s, you put me on some blue ribbon so-called panel that had to do with access to vaccine safety data, and no less, at CDC. And there came to wrestle with some demands for increased transparency on the behalf of the general public, but also, as it happened, with people who were questioning the safety and effectiveness of vaccines as well. So I think that's where it dates back to. I also did quite a bit of work on this when I was at FDA for a while.
Well, I'm really looking forward to this conversation. And I guess I'd like to start with what we're talking about here, which is when CDC is communicating, how does it develop its communications and how does it explain its communications? And Dr. Marine, you mentioned that this was a source of some frustration for you during the pandemic. Could you explain a little bit more about that?
Sure. I think the public had a lot of problems and questions with a number of guidance that the CDC came up with, both how did they come up with the guidance, how they communicated it, the degree of certainty with which they communicated it. Just take, masking young children, for example. I think there was a lot of uncertainty about how that recommendation was made. There was a lot of differences between different countries. There was different rates of adoption by different societies, and it seemed to me that it was not really clear at all how the CDC came up with that guidance, and it was really the subject of a lot of concern and even division and ridicule that I think undermined many of the other recommendations that the government health agencies made.
In other words, people may have had questions, but the way the CDC was communicating their positions, those questions weren't being answered, or maybe people might even felt like those questions were being dismissed.
I think so. I mean, the guidance came down. There was really no way to challenge or question it from the public standpoint. And many of the local public health authorities and institutions sort of adopted CDC guidance as a reflex that, well, if the CDC recommends it, it must be true, and therefore we have to impose it by mandates upon everyone. And I think that led to a lot of backlash and a lot of counter-reaction from the public.
Dr. Lurie, talk to me about your perspective on some of these communications, where you saw some challenges in how the CDC communicated with the public.
Well, I do think one thing we have to distinguish is where people objected to the content of the guidance as opposed to whether people were objecting to the method, as it were, or the process of the guidance. And not infrequently, people who don't like the content turn to the process and complain about that instead. So we do need to separate them. That is not to say that there weren't issues in the transparency of the process. And I do think that CDC found itself in a bind. It found a strong demand from the public for clear and decisive answers, and it sought to provide them. Sometimes it turned out that the science evolved and the recommendation just given turned out to be a bit out of date. It was a rapidly evolving pandemic after all. And I think that in some people's minds showed a lack of trustworthiness on the part of the agency when, in my view at least, in most instances, it was a good faith attempt to deal with evolving science and the fact that recommendations were legitimately changing. I think one thing that Dr. Marine seems to be raising here is the opportunity for input from the public into draft guidances, as it were. It's in effect what you're proposing. And Josh, when you and I were at FDA, of course, that was something we're very much used to. The guidances came out in draft form in almost every instance. There's opportunity for public comment. FDA has to take those into account, and then they have to change the guidance or at least address the concerns raised. That is not something I've ever seen at CDC. And it feels revolutionary, honestly. Maybe some occasional guidances, say maybe on opioid prescribing, there was a process, something like that. But generally speaking, I think there's a tendency to develop guidance internally and not to air it out enough with outside folks, and then to provide it to the public. And then sometimes mistakes are made.
Well, I want to delve into that a little bit more because often when draft guidances go out at the Food and Drug Administration, they not only have what the guidance would be, but they have the justification, the explanation, the evidence behind it. So the process of putting out a draft forces the agency to explain its thinking and then, as you said, defend its thinking or change its thinking based on comments that are received. Dr. Marine, do you have any thoughts on this dimension? I know there's some more we're going to explore of whether there's a role for proposing guidances rather than just releasing guidances, and whether you think that might have been helpful in addressing some of the concerns that you had.
Absolutely. I think if time allows, then having more peer review and even public review is a great process. And that's something that most of the professional societies, certainly the cardiology professional societies, do routinely when they develop their guidance. The draft guidance is written. It then goes through a peer review process. Multiple different societies then lay eyes on it. The board of directors of each society has to approve it, or a designee. And then some of the societies are even opening up the major recommendations to the entire membership of that society to comment upon. So that's certainly a very healthy process. Of course, it does add time, so that has to be tailored to the time sensitivity of the guidance.
Yeah, and thank you. And Dr. Lurie, you also raised the question of nuance, that like sometimes in explaining something, you have to get into detail, and that level of detail may be hard to explain. And when people are looking for simpler answers, or at least there's a perception that people are looking for simpler answers, or at least reporters are asking for simpler answers, that can be difficult. How do you see that kind of intersecting with this idea of a more thoughtful communication process?
Well, I don't want to do a disservice to what CDC does because I can't say that I know everything they do. But my sense of it is that the communications that come out are almost a one-size-fits-all kind of approach. And what really would be helpful, I think, is if you had multiple tiered levels of communication. At some degree, I'm sure they do this, but it would clearly mark for the public, for industry, for academics, as it were, for reporters, for this, for that, and took that into account. What we get, I think, instead is something more of a one-size-fits-all approach. And then the public can be confused because the language can be too technical. And then the academic type community is frustrated because perhaps undue certainty is expressed about something, that things are just stated as 6 feet, right? Good example. And not 6 feet plus or minus 2 feet, right? They don't say that. They say 6 feet. It's almost as if you need to have somewhat different but not contradictory messages going out to different audiences.
So we're identifying along the way here some of the challenges in communication to different audiences. Like Dr. Marine said, the timeline may not be optimal to do the full process that you want. So how do you adjust the process to fit the timeline? I want to turn back to something that Dr. Marine, you mentioned at the beginning, which is grading the evidence. Could you explain that a little bit?
Sure. So the cardiology societies, when they put out guidance, they grade the evidence behind it on an A, B, and C scale, where A is the highest level of evidence and C is the lowest level of evidence. The B and the C is then divided into two subcategories. So we essentially have 5 different grades, where the highest level of evidence is multiple high-quality randomized controlled trials or meta-analyses, and the lowest level evidence is expert opinion without any other evidence behind it. And then there's a whole range of studies that would fall in the in-between category. So that's kind of has two purposes. One is it signals to the public and the professional community how the degree of evidence and certainty behind a guideline. And two, it signals to the community where more research is needed.
So in the context of COVID, could you give an example of what might have been an A or a B or a C, or how that might have played out?
Sure. Well, I think, in 2021, certainly for high-risk groups, the COVID vaccines had high-level evidence A behind their use, where you might say that masking 2-year-olds would be a level of C expert opinion.
Dr. Lurie, what do you think of this idea? Let me start there.
Yeah, well, I guess I have 2 thoughts, and they may even be contradictory. The first is, I'm not sure this is appropriate, for every circumstance, right? We've already acknowledged here that speed really matters, and especially in a pandemic. This feels to me like a months-long process, even perhaps a year or more, depending on the complexity of the question being asked. So I don't think it's very well suited for a certain fraction of the communications that CDC has to engage in. My second impulse is to say, I don't think that kind of complexity is too much to convey. I'm struck by, when I read, at least in newspapers that have more space, or maybe that are just better, this kind of complexity is conveyed nowadays in newspapers. You do get this stuff where it comes out and says, well, the U.S. Preventive Services Task Force just did the following, and they decided that it was level this level of that, or they might say this is limited evidence or moderate, and all of that. I do see much more of that creeping into the mainstream media. I see that as really a positive development. And that is part of the educational process for the public, right? That they come to understand that it's not just this number, it's this number with this amount of certainty. So I think I'm optimistic for the ability of the media to convey it, and I'm optimistic of the ability of the public to learn to understand it.
So what I hear you saying is that the full American College of Cardiology rating scale might be complicated, but something else out there that would allow CDC to communicate the strength of the evidence might be appropriate. What do you think about that, Dr. Marine?
Yes, I think so. I think that this isn't necessarily the best way to do it for the CDC, but the concept, I think, is valid for any enterprise where you're communicating medical scientific information.
And people could then take that information into account. So, this is something that the CDC is saying is extremely important, and this is something that is emerging and seems like a good recommendation to people, but we're waiting for the definitive evidence, or we're going to be adding more evidence as we understand it.
And there's 2 different sets of grades. There's the recommendation grade itself, which comes in 1, 2, and 3. And a level 1 recommendation is the strongest recommendation, where there's a fair degree of confidence behind it, as well as strength of the recommendation. A level 2 recommendation is more of a moderate recommendation, and a level 3 recommendation in the ACC is actually a contraindication or a counter recommendation.
Interesting. Dr. Lurie?
The terms need a definition. For example, we have a Dietary Guidelines for Americans Advisory Committee just came out with a recommendation that had to do with ultra-processed foods, and they concluded that there was limited evidence that they were associated with various chronic diseases. Some people would say, limited, okay, well, all right, that's good. I'm worried about that. And, some people in the research world be like, oh, limited, forget about it. That's that. So even that, right? You try to use words that appear to have simple connotations. Even that requires some degree of definition for the public. But again, I feel like it's a learning process, and if people come to understand CDC communicates in this way, high, medium, low, or major, limited, moderate, people will come to recognize those terms over time. And I think they can become meaningful.
In a way, you're saying there needs to be a lot of transparency about the transparency.
That's the way of putting it.
Last question for each of you. How does this discussion relate to trust? We're not getting into what's happening today, that when we're recording at the CDC, it's been a tumultuous period, but looking over the longer term, if CDC can communicate more effectively in these ways with the American people, how do you think that affects this question of trust that we've been hearing a lot about? Dr. Lurie, maybe I'll start with you.
Well, I certainly think it does. I mean, part of the problem in COVID was there was, it was a tumultuous period within CDC even then, and people were coming and going, and there was a roster of changing faces at the press release, at the press conferences, and that really didn't help at all. There was evidence that there was behind the scenes discord over questions, that there was influence from the department over the CDC. All of those things undermine public trust. And trust is not an abstract concept, right? Trust matters on the ground, because at the end of the day, trust is converted into vaccination rates, whether or not people cook their eggs properly, what have you. All these things matter concretely in people's lives. And when you erode trust from people who are giving the advice, that advice is much less likely to be heeded.
Dr. Marine, the last word.
Yeah, trust is absolutely critical to the practice of medicine. It's something I've learned early on. And as I think, as you know, Josh, it's kind of an unofficial motto of Johns Hopkins that medicine is a public trust. And without that trust, there's really very little that we can do. One thing that I learned in crisis communication is that two of the most important things are to never say something that's not correct and to be clear about what you don't know. Because if you don't, trust becomes damaged. And we have evidence from a number of sources that trust in the whole biomedical enterprise has declined over the past 5 years. And so restoration of trust really needs to be at the top of the agenda of every medical and healthcare organization.
Well, thank you both for this fascinating conversation. I think we're talking about different pathways to enhancing trust. And I hope that as things calm down, some of these ideas can be put into practice. So I really appreciate both of your time.
Thank you for having me.
Thank you, Josh. Thank you, Dr. Lurie.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.